If you enjoy listening to clinical conversations, then maybe you'd enjoy membership with the Royal College of Physicians of Edinburgh. As a member of the Royal College of Physicians of Edinburgh, you'll have access to the RCPE education portal and access to the evening medical updates and options to view the symposia in person or online. If you would like to learn more about this, then please go on to the Royal College of Physicians of Edinburgh website for more information. Thank you.
Hello and welcome to our next episode of Clinical Conversations provided by the Royal College of Physicians, Edinburgh Trainees and Members Committee. My name is Anda Bularga and I'm a T&MC member. I'm delighted to talk to Dr Eoin O'Sullivan, Renal Medicine Doctor in NHS Lothian and Kidney Research UK Fellow at the University of Edinburgh. Dr O'Sullivan is passionate about medical education and has an ongoing interest in evolving research around clinical decision making. Today we're going to explore this topic and talk about cognitive bias and its impact on decision making. Welcome, Eoin, and thank you very much for your time.
Thanks very much, Anna. Good to be here.
So in 2018, you published a great review on cognitive bias and clinical decision making in the Journal of the Royal College of Physicians, Edinburgh. Today, I'm hoping that we can summarize some of the main learning points from the article. But before we start, I was hoping you can tell us a bit more about your interest in clinical decision making and the research around cognitive bias. Where did this originate and how have you developed it over time?
So I suppose I should probably begin by saying that I'm an enthusiast rather than an expert. And while I've published a bit on the topic and I've run a trial of an intervention, I think it's very much an emerging field and something that I'm kind of only increasingly beginning to learn about myself. So I guess my interest began when I picked up quite a well-read book now, Thinking Fast and Slow by Daniel Kahneman. So if you haven't read it, you really should. I think it's a New York Times bestseller and it brings together just decades of Kahneman's work on cognitive psychology. And ultimately, he won a Nobel Prize in economics, actually, for a lot of this. And it was really eye-opening because it discusses all the various ways in which we think we're being very clever, we think we're making brilliant decisions, but actually the machinery of our thoughts results in, really, really substantial errors. And while it wasn't about medicine, and none of his case studies were medical, it was really easy to see how it could project onto our work clinically. And at the time, I was looking for a research focus for a master's I was doing, and this natural enthusiasm fed into that. So I started thinking more and more about how this could apply to my own clinical work, how it could apply to research, started looking at interventions for this. And that's kind of where it all began, really.
That's very, very interesting. And so from your kind of initial reading around it, why do you think that decision-making and clinical diagnosis matter?
So every day, as you know, we make thousands potentially of clinical decisions. And to put it simply, when we make a bad decision, it tends to lead to bad patient outcomes and it sucks up a lot of the finite resources that we do have. And I suppose a lot of the literature focuses on clinical diagnosis as the sort of most important decision that we will make. And intuitively that it is the foundation really of the subsequent care for anyone. And I don't think we realize just how poor we can actually be at this. So, just to throw some numbers on this, up to 15% of our diagnoses, when you do retrospective analysis of cases, they're wrong. They're often completely wildly wrong. There's a huge discrepancy between what's written on death certs and what is found on subsequent postmortems, I think up to 30% in some series. So we're really not that good at doing it. And in terms of the scale of the issue, it's estimated that about 30% of avoidable deaths in the UK, medically speaking, are related to misdiagnosis. And if you're more litigiously minded in the US, which is obviously culturally different, but 50% of all of the court cases taken in medical litigation are due to misdiagnosis. So it's huge. And, if you just start looking for this, you'll start finding huge numbers, 12 million Americans, 100 billion could be saved and so on. You can just start putting zeros onto all the numbers with great prejudice and see it's a huge problem. And I suppose what is interesting, just to finish on that, is that while the scale of the problem is huge, most medical schools, and certainly mine, didn't really touch on this. And it's only recently that we've even begun to come across it in our postgraduate learnings, and not in a systematic and integrated way. So it matters for those reasons.
Yeah, that's a huge problem and scale as you describe. And I'm very interested that we touch a bit later on education around this topic. So how does where does cognitive bias come into this, and how does it lead to medical error?
Yeah, so I suppose the first thing is, it's worth briefly, in very, very broad strokes, just thinking about how we actually make decisions. And there's loads of these fancy psychological models. There's dozens of them, these hypothetical deductive approaches and heuristic-based approaches. And it's all a little baffling to a non-expert, and certainly to me. But you can lump them briefly into two big buckets, two big approaches. There's these intuitive, fast sort of ways that we make diagnosis. This is the really quick spot diagnosis. And then there's these slow analytical ones. And this is the model by which most modern psychologists feel that we make our clinical diagnosis. We use one of these two models, the fast ones or the slow ones. And they tend to call them system 1 and system 2. And I can talk about it in a little more detail if you want, but cognitive bias, to answer your question, comes in when the way in which we address a problem, the sequence of steps, the mechanics of our thoughts lead us away from rationality and lead us away from correct thinking. And it makes us misinterpret the data that's in front of us. And I guess, maybe just to dig down on that a little bit more, it's worth thinking about the difference between these kind of type 1 and type 2 thinking, because a lot of the literature goes into this in a lot of depth. And I'll explain why in a second. So this fast type 1, these are pattern recognition. It's easy. It's what the experts will often do very, very naturally and quickly. And it's really easy to do this. It's cognitively, it doesn't place a lot of burden on ourselves, right? So we spend 80, maybe 90% of our time walking around making decisions like this. It's susceptible to bias because it's quick. We're not super, super engaged with the process by which we're making these decisions. We're just looking at an ECG, looking at an X-ray, looking at a patient and snapping our fingers and saying, yeah, that's the problem. In contrast, type 2 thinking, this slow, deliberative, where you sit down with a cup of coffee and really try and put all the pieces together, where you're analyzing everything very, very thoughtfully, you're better able to spot incorrect approaches and biases as they emerge and de-bias yourself, so you can see the mistake ahead and say, actually, that's a red herring, I'm going to ignore that, or whatever. And the feeling is that most of the errors that we can go into in a minute, most of the kind of cognitive biases are going to occur in type 1. And type 2 is this way in which we might perhaps mitigate against these biases, cancel them out, de-bias ourselves. So that's the kind of model of how we think. That's how cognitive bias fits into that model. And a lot of the discussion in the field really fits around how we might decide when to activate type 2 thinking and when not to, because it takes a lot of work. It's a real headache to sit down with a cup of coffee and put pieces together. It's cognitively a lot more burdensome. And in real life, we need a blend. You can't go around analytically thinking about everything because you'll go crazy and get nothing done. But equally, you can't shoot from the hip all day because you will make a mistake. So the skill of an expert comes from when they know when to deploy each way of thinking. And that's, I guess, where the artfulness of medicine comes in. But, what's really interesting actually is that this is more than just psychological postulating. Like if you look at functional MRI studies, there's a few papers like this, and you look at people in system 1 or system 2 thinking, completely different parts of your brain light up. You have completely different glucose metabolics in there. There's meaningful changes physiologically that happens when you think in different ways and when you're making a mistake and when you're de-biasing yourself. So it's not completely theoretical, actually.
I think it's fascinating that we can map this and see this process, with MRI techniques. When you talked about bias, you talked plural biases, and perhaps would be useful if you could give us some examples of the types of cognitive bias and maybe scenarios.
Yeah, of course. So it all sounds a bit theoretical, doesn't it? So the first thing to say is that there's hundreds of these, and there's these big, long, wonderful lists that you can dig into when you're curious about it. And the second thing to say is that it's not entirely clear which are the most important ones, which are the ones causing the most harm, which are the ones that are easiest to commit, because it's going to be different for everyone. It's fully contextual because you and I are completely different thinkers. We'll have different clinical scenarios. We'll have our own personal proclivities towards certain biases and so on. So I'll give you some common ones, but it's worth knowing that the things that are relevant to you in your practice might actually be very different. So there's a huge amount of personalization and reflection that has to go on. So, simple ones first. We'll just take maybe 2 or 3. Search satisfying. So I think a lot of us have probably come across this in our training. It's one of the ones that has seeped into mainstream education. And the simplest example is, imagine you're looking at an X-ray and you see pneumonia, okay? So you get a little kick of dopamine, you high-five the team, pneumonia, job's done, thumbs up, antibiotics and so on. But of course, the pitfall is that if you don't keep systematically working through that x-ray, you might miss that, apical tumor hidden away contralaterally or what have you. This is the same reason you need to come back and do secondary surveys and polytrauma and so on. And it's because our brains are primed to stop when we have found that big obvious problem. We get satisfaction. We think we've done a good job. It's cognitively, it's effort to keep on going and keep searching. It's irrational to stop at one problem. There's no reason to stop at one problem, but we do. So we do this all the time. And on a medical ward, as soon as you've got one big diagnosis, there's a tendency to stop working away systematically through all the rest of your blood tests and ECGs and so on. And in doing so, you can miss secondary related or unrelated problems. So that would be search satisfying. And I think that's very intuitive to a lot of us. Another one actually that I see a lot kind of doing consults, say someone comes in the front door, perhaps they're seen by someone senior, okay, and they're given a label of a pneumonia. What can happen is they'll be admitted to medicine. So the baton is passed between teams, perhaps to a more junior person, and they look at the notes and say, sure, pneumonia. Who are they to argue, okay? Antibiotics will get started. Maybe it's the middle of the night. And you can see how this is going. The next day, it's a busy round. Now there's 2 doctors who've written acute pneumonia in the notes. So if you're seeing this, you're going to, quite dutifully toe the line. Maybe they'll check the cultures and add to that narrative. And the tendency then is that you might ignore perhaps the blood pressure and the SATs are a little low, but you might say, look, we're only 24 hours into this treatment. Maybe that's reasonable. And it's only much, much later when someone perhaps from outside the team or someone much more senior comes along, and despite the fact there's now 3 doctors having written pneumonia in the notes, they'll actually stop and look at the x-ray properly and say, actually, that doesn't quite fit. And now this spectre of perhaps a PE or an MI begins to loom, and you're playing catch up and so on, and potentially a patient is coming to harm. And that's diagnostic momentum, which I think is really descriptive. You can see the momentum from the beginning. The label's stuck, and these labels are sticky. And especially if someone senior has said this, and if you're more junior to them, there's a confidence thing. You may not have enough medical background knowledge to feel that you can really challenge this, or you might just, it's easier cognitively to just accept it. Like, it takes a lot of work to stop everything and go back to the start. And actually that happens a lot. And I think you see it when you're doing consults a lot, because you're coming in as an outsider with fresh eyes and you haven't been part of that journey. You're kind of less likely to fall for it. So that's another really common one that I really like. And I guess the message there is that it's really key, I think, always to trust but verify, be sort of politely cynical about everything, and just always take a big step back and say, is everyone really sure about this? And then, you asked for a few. I'll give you one more because I know I'm talking a lot here, but let's say framing is a really common one. All right. So a great example, if a psychiatrist refers in a tachypneic patient for assessment, okay, and says, I'd like you to confirm my suspicion here, please, that this woman has anxiety-related hyperventilation. I presented that in a very specific way, and that is framed in such a way that you're much more likely to miss a PE than simply saying there's a tachypneic woman who's presented for assessment. And, you might think that that's really ham-fisted and, no one's going to fall for that. But actually in Edinburgh, during the trial I ran, I asked, maybe 100 people or so, 3/4 of them fell for it and completely missed the PE, despite her being hypoxic and having a couple of risk factors. And the reason was I framed it in that way, and I threw in some red herrings to make it look like I was actually asking about how to manage acute psychiatric illness and so on. And, we encounter this a lot. And it's a little bit related to diagnostic momentum, isn't it? But how things are framed completely influences how we approach it. And this is how advertisers, pharmaceutical companies or just advertisers in our daily life, they frame things to us in such a way that they're really leading us, leading the witness. They're leading us where they want us to go. Be really thoughtful about how things are framed when you approach them. So, those are 3 obvious, easy ones. I think we can all kind of see how we've encountered them. But what applies to you specifically, it would be for you to find out, I think.
Very relevant, I must say, just from what you're telling us. Yeah. I can see how those are implied, day-to-day clinical decision-making. And thanks for giving us those examples. Yeah. So what I'm thinking about is, in medicine, we learn continuously, evidence-based, it's growing, we acquire new information throughout, training, careers. How does cognitive bias that we just discussed impact, information acquisition and new learning? How these kind of old perceptions or experiences affect the way we can acquire new knowledge and change practice?
Yeah, So from the literature, it's actually easier to answer your question in reverse. How does new learning influence bias? Because experience is actually hugely impactful in helping inoculate yourself against bias. So we know that everyone is susceptible to these biases. It doesn't matter your IQ, your level of seniority, and so on. But what we do know is that the more expert you are, the more knowledge you have in an area, the less likely you are to make a bias. It never hits zero, never gets close to it, but it does improve. So learning more and having a really robust schema of information about a topic makes it easier to avoid mistakes, makes it easier to see the red flags, makes it easier to avoid, incorrect framing and diagnostic momentum, as we just said, and so on. So you can make yourself resistant in that way. So that's the key interaction there. And there's also ideas that learning in a very structured, expert, sort of schematic way, and I'll explain that in a sec, can help again to inoculate against bias if you're very junior. So what I mean by that is junior practitioners in anything, but we'll say clinically in medicine, they tend to learn by just kind of trying to absorb a ton of information and try and memorize facts and lists. And it's not highly structured. Whereas the way experts tend to retain information is in like a very, very precise and bespoke filing cabinet almost. So they've divided things into a flow or a schema that works for them. Maybe emergencies, non-emergencies. They're making connections and integrating things very, very carefully and thoughtfully so that when they learn new knowledge, they know exactly where to file it. If they're learning about a new disease or new medicine, they have a context they can just slip it into quickly. And it benefits then from all of the anti-biasing you've done in the past. Whereas if you teach more junior practitioners how to do that, if you teach them how experts think about problems, they can gain some of the benefits of the expert's schema without being an expert themselves. And that's been demonstrated in sort of case study orientated trials. So I think that's the big interaction between bias and learning. Does bias make you, how does bias interact with learning in the forward sense of that relationship? I think that's not as clear actually. We know learning can help bias, but does bias impact your learning? I'm not sure. There's nothing written about that. So it's something that needs to be looked at, I guess.
So you described one way to mitigate bias. Any other ways in which we can mitigate the effect of cognitive bias in day-to-day clinical practice? Yeah.
I mean, that's the real question, isn't it? And this is the big gap, I think, one of the big gaps in our knowledge. Why not just come up with clever strategies to debias ourselves? It'll never be a problem again, and we just can move on with our lives. I suppose it's clearly not as easy as that sounds, is it? So there's many, many reasons, right? So the first is that a lot of us are unaware of when we're making mistakes and when we have biases. And there's lots of reasons for that. It can be psychological defense mechanisms. We don't want to admit we're wrong, perhaps. We don't want to examine our motivations and desires too closely. It's a bit uncomfortable and confronting. But also, we tend to be overconfident. And it's well demonstrated that people in general are overconfident, and that when you tend to make more mistakes. And there's also a hindsight bias. You look back and you tend to rearrange the facts of the past just subtly to fit your own narrative. And there's a blind spot bias where we're actually not too bad at seeing others' bias, but it's demonstrably harder to see our own. So even before we begin to talk about how we can debias ourselves, it's worth acknowledging the various challenges. And that's not even to touch on the challenges of designing interventions and trying to prove that these things actually work. Really heterogeneous samples of people. It's hard to simulate clinical environments. People are so different that you need huge sample sizes to try and power these things. It's hard to know if your intervention is even being implemented. So, one of the things I've come to respect, having done a lot of much more technical science and hard science, is actually doing research on human beings is pretty tricky stuff. So respect to those who can. In terms of what works then, with all that said, it's worth thinking of like Carl Sagan, I guess, and thinking, absence of evidence here doesn't necessarily mean that there's the evidence of absence of efficacy, right? The one that is most commonly espoused is slowing down. So type 2 thinking that I mentioned earlier, it's slower, it's deliberative. If you literally slow down, just stop physically and stop rushing on to the next case and invest some time into what you're doing, you will naturally become more inclined to use type 2 thinking. You will naturally start to spot inaccuracies, biases, things you've overlooked. Perhaps you'll spot that momentum. You'll see it's been framed by the referral letter in a particular way. So slowing down does actually help. The data is overall suggests that it does. It's a little bit mixed, but I think that's more to do with how the studies are done. It does suggest that slowing down helps. The problem is, of course, slowing down is really hard when the most valuable resource in our daily lives is time. But I guess, as I mentioned, knowing when to slow down, spotting that this case is not straightforward. I'm not sure why something is up. Let's just stop. Or someone has been re-referred in, that kind of red flag. It's their second time, third time presenting. Stop, slow down. Don't just rush over this one. Another way that we can help that has some evidence to support it is this idea of metacognition. So metacognition is just a fancy way of saying thinking about thinking. And we do this all the time. But what's fascinating is that very, very simple approaches can be helpful. So there's a really lovely little study showing that actually just saying to someone when you hand them a case, this is a really tough case, ramps up their diagnostic accuracy because it primes them to look out for problems. And similarly, if they say to themselves, this is a tough case, they become more accurate, which seems almost childish in its simplicity, but that's what you need to do. That's how metacognition works. Other classic kind of questions you can ask yourself that are part of this. What's the worst case scenario if I'm wrong? So that's a kind of a front door medicine sort of approach, but it does work. And when I say it does work, there's some data to support this. This isn't my opinion. Asking questions like, does all the data fit into my hypothesis here? That's also very effective. You can see that, while you're thinking about your pneumonia, there's a troponin leak that maybe it's a bit more than you're comfortable with, that sort of thing. Similarly, the corollary of that is, what data is missing? If this is my hypothesis, why don't I have X, Y, and Z to prove it? And it's checking your own confidence again. How confident am I? And why is that? And asking yourself that follow-up why. So if you say, actually, I'm only mediumly confident in this, why is that? And then you say, well, actually, it's because they don't look quite right. And then you start to unpack and confront those little things that you may have glossed over when you were in type 1 thinking and just racing towards a conclusion. So, these are intuitive questions. And I think as we practice more, a lot of us tend to ask ourselves these questions more. Or if we take a case to our colleagues over coffee or whatever, these are the questions you tend to bounce off each other. But this is why it's triggering metacognition. And then I suppose just one last one is just the humble checklist. I hate checklists, but actually I've come to respect them. Maybe it's I'm just running out of bandwidth mentally, but there's definitely a role for them and there's some evidence to support them too. You just have to be very thoughtful where you deploy them. So they work pretty well in very constrained situations and they work better when you're more junior. So I think probably the most successful one I've seen was interpreting ECGs. So it's a really, really tightly focused task. They don't perform particularly well in unselected take emergency departments and so on. You need to use them like kind of a surgical instrument, really. But when you do use them properly, they can be great. They force you to consider data and decisions that you might miss. Simple, we've known about them forever. It's just a case of thoughtful deployment rather than, harassing junior doctors with my checklists. I don't think that's necessarily progress. So those are three probably of the best supported approaches.
Really like the idea of thinking about thinking. That's a great one, I think, and presume that's how you do the transition, as you said, from type 1 thinking to type 2 thinking.
Yeah.
So we talk about the topic, and I was just wondering, training around this and training in underlying thought process, clinical decision making, and cognitive bias. You touched a bit at the beginning. How important do you think this is, and how can we do it better? Because I think we're lacking some of that at present.
Yeah, so I think I recently read that less than half of the medical curricula in the US, and I don't know if it's been looked at in the UK, even talk about clinical decision making. And it's not even clear whether they would incorporate maybe the more recent ideas about bias and so on. Educational interventions, they can work, but you're as likely to find a positive study as you are a negative one. So I think what that means is that it's not really clear what the optimal form should be. And I'm not sure I have an answer really, but we do know that you need to make your decisions, you need to have your knowledge base. So we have to maintain that important traditional education. I suspect that the most effective intervention in terms of integrating into training is to do just that, is to integrate it as we train from an early age and to introduce the ideas and the concepts and just to highlight them as over the years so that they just become second nature. Isolated teaching events, kind of these ad hoc drop-in sessions or little kind of smash and grab interventions, they tend to fail pretty miserably, actually. And they tend not to be very useful either for students. I think pretty much all the student trials that I can remember reading were unsuccessful. Whereas when you're actually practicing and you see the relevance of these sort of things, I think it obviously becomes more interesting and more important for you to integrate it into your practice. So there is a fairly consistent beneficial signal, but as to the form that the education should take, I think is an unknown entity. My feeling is to integrate it early and just make it part of the wallpaper of medical education. And that's probably, can't swear, but that's what I would do.
And what about reflective practice? We know that we're encouraged to do that throughout our education and training and career. Is there a role for reflection when considering cognitive bias?
Yeah, I think there is. I mean, because to me, reflection overlaps hugely with metacognition that we were just talking about. And, it's by sitting down and thinking and reflecting on decisions that you made, acknowledging that it's harder to do it in retrospect than it is at the time. Well, it can be harder. I think that's where the overlap is. So I think it can trigger those sort of metacognitive events where you look back and so I think there's value in reflection. I think that's the overlap there. And, I think a really good time for that is at the M&M process, which we should all be involved in and part of. And I think it is in many departments. I was recently in a department where during the M&M, some of the participants started reflecting on a decision that was made and kind of articulating the various biases they felt were present at the time. And it was a really eye-opening experience to listen to that. I thought it was really useful because I think a lot of the other listeners were learning more. It was more enriching for the other participants and probably was better for patient care overall because you take more away from that. And that was hugely encouraging. And I think every M&M I've ever been in, you can sit there and often notice little biases that could have crept, or big biases that could have crept in and influenced decisions at various points. And I think articulating them out loud and sharing them with the room and exploring them could be hugely beneficial. So that's something in practice that I think we could be doing out with, the more educationally oriented reflection, kind of portfolio level reflection.
That's a very good example, I think. In terms of, so we talked a bit about education around the topic and you described your experience and your research. Are there opportunities for, medical students, trainees, clinicians to get involved and work around it? Or what would you advise?
Yeah, so there definitely are opportunities. I think it's a really accessible area of research because for one, you don't need a multi-million pound omics lab. So that's a nice start. But you do need to be very thoughtful and careful, particularly about your, experimental design, and it's very much a multidisciplinary sort of area. What's really interesting, and I would love to flag up to anyone interested, is that there's a website called improveddiagnosis.org, and that has only been birthed in the last few years. And it is the website of the Society to Improve Diagnosis in Medicine, which is not a catchy title, but is actually a very cool society that has been formed by a lot of the kind of thought leaders in the field. And it's pretty much a one-stop shop for anyone who wants to get involved in this because it discusses QI projects, research projects. It essentially gives you all of the kind of the guidance you need to slip into the field and get up to speed on thoughts. It has components for educators, so those people who are teaching medical students and postgrads. It has resources for those who want to implement change in their own units. It has funding calls. It's just really pretty much like the hub for kind of cognitive bias and decision making. So it's not a nascent field. I mean, this has been around since the kind of middle of last century, but it's only really in the last decade or two, maybe three, that it's kind of bubbling up in clinical medicine. So it's a good time to get involved. There's a lot of interest. There's increasing amounts of funding being directed at this. And there's kind of an emerging community of practitioners and researchers who are really, really passionate about this. So improveddiagnosis.org is probably where you'd want to start that journey.
Thank you very much. We'll link the website to this episode and hopefully the listeners will be able to have a look there. Thank you very much. We've had a very thought-provoking discussion today, and thanks for sharing your knowledge and also experience around the topic. And there will be a few take-home messages. What would you say in terms of clinical decision-making?
Yeah. So I think take-home messages would be that, one, just be aware that making decisions is tricky and we often get it wrong. And I think even just accepting that is the first important thing, that you're going to get it wrong. The second message would be slow down and look for opportunities to slow down and start thinking and asking yourself questions about your decisions. Interrogate yourself, just cross-examine yourself continually, particularly when you're in difficult situations. And that will probably keep you right. And I think you probably should cut me off before the word "and," because I think two is plenty. I think those would be my key messages to take home.
Well, thank you very much for your time. I really appreciate that. It was a pleasure to speak to you.
All right, no worries.